Hello everyone. For my microbial disease presentation, I will be covering 3 sexually transmitted diseases. I will start with nongonococcal urethritis, followed by lymphogranuloma venereum, and finally Chancroid. Nongonococcal urethritis is a lower urinary tract infection that refers to inflammation of the urethra caused by pathogens other than Neisseria gonorrhoeae. Pathogens that cause nongonococcal urethritis include Chlamydia trachomatis, Mycoplasma genitalium, Trichomonas vaginalis, herpes simplex virus, adenovirus, and many more. For this presentation, though, I will only be talking about the sexually transmittable causative agent, Chlamydia trachomatis. Chlamydia trachomatis is the most common cause of nongonococcal urethritis. It is a sexually transmitted bacterial agent that accounts for 15 to 40% of all nongonococcal urethritis cases. Chlamydia trachomatis is characterized as a small, gram-negative, obligate intracellular parasitic bacterium. It is aerobic, coccoid or rod-shaped, and its cell wall lacks peptidoglycan. Therefore, Chlamydia trachomatis is not visible on a gram stain and makes beta-lactam antimicrobials ineffective. Chlamydia trachomatis is also divided into 3 biovars and are further subtyped by serovars. Biovars are strains of the same species but are biochemically different, whereas serovars have different antigenic properties. The 3 biovars of Chlamydia trachomatis are the trachoma biovar, serovars A through C, the genital tract biovar, serovars D through K, and the lymphogranuloma venereum biovar, serovars L1 through L3. Nongonococcal urethritis is a result of contracting the genital tract biovar, which affects genital tract epithelial cells. As I talk about Chlamydia trachomatis in regard to nongonococcal urethritis, I will be referring to the genital tract biovar. The mechanism of contracting Chlamydia trachomatis is through sex that involves direct mucous membrane contact with an infected individual. This can be seen as vaginal, anal, or oral sex. The pathogen can also be passed by sharing sex toys or by touching the genitals with fingers that have infected fluids on them. Ejaculation does not have to occur to infect or be infected. Let me preface this next part by saying that all species in the genus Chlamydia share the same mechanism and developmental cycle in which they alternate between the extracellular infectious alimentary body and the intracellular non-infectious reticulate body. The mechanism of disease for Chlamydia trachomatis begins once the pathogen enters the host. The binding of elementary bodies to the host cells is then initiated by the formation of a trimolecular bridge between bacterial adhesions, host receptors, and host heparin sulfate proteoglycans. Next, pre-synthesized type 3 secretion system effectors are injected into the host cell, some of which initiate cytoskeletal rearrangements to facilitate internalization and or initiate mitogenic signaling to establish an anti-apoptotic state. The elementary body is endocytosed into membrane-bound compartment known as the inclusion, which rapidly dissociates from the canonical endolysosomal pathway. Bacterial protein synthesis begins, elementary bodies convert to reticulate bodies, and newly secreted inclusion membrane proteins, called inks, promote nutrient acquisition by redirecting exocytic vesicles that are in transit from the Golgi apparatus to the plasma membrane. The nascent inclusion is transported, probably by an ink, along microtubules to the microtubule organizing center or centrosome. During mid-cycle, the reticulate bodies replicate exponentially and secrete additional effectors that modulate processes in the host cell. Under conditions of stress, the reticulate bodies enter a persistent state and transition to enlarged aberrant bodies. The bacteria can be reactivated upon the removal of the stress. During the late stages of infection, reticulate bodies secrete late-cycle effectors and synthesize elementary body-specific effectors before differentiating back to elementary bodies. Elementary bodies exit the host through lysis or extrusion. Chlamydia trachomatis is the most prevalent sexually transmitted bacterium that causes nongonococcal urethritis in men and women. The disease causes mild symptoms and is commonly asymptomatic. In fact, roughly 40% of all patients diagnosed with nongonococcal urethritis are asymptomatic. On top of that, 70 to 80% of women are reported asymptomatic. If symptomatic, symptoms may vary based on the causative agent. Common symptoms of nongonococcal urethritis include dysuria, itching, irritation, and tenderness. Symptomatic patients infected by Chlamydia trachomatis genital tract biovar may experience dysuria and urethral discharge. If left untreated, females may even develop cervicitis, which is an infection in the cervix that includes intermenstrual vaginal bleeding, postcoital bleeding, and changes in vaginal discharge. Pelvic inflammatory disease, which is an infection in the female reproductive organs, and infertility. Males may develop mucopurulent or watery discharge, penile burning, epididymitis, where the epididymis becomes inflamed, and infertility. Diagnosis of urethritis can be verified based on the presence of mucoid, mucopurulent, or purulent discharge from the urethra. Urethritis can also be verified by laboratory tests such as a gram stain of urethral secretions demonstrating greater than or equal to 2 white blood cells per oil immersion field, or by a positive leukocyte esterase test on urinalysis or microscopic examination of sediment from a spun first void urine demonstrating greater than or equal to 10 white blood cells per high power field. However, the diagnosis of nongonococcal urethritis requires the exclusion of the gonococcal urethritis agent Neisseria gonorrhoeae. This can be achieved with a gram stain that lacks gram-negative diplococci or by any negative gonorrhea test, such as a nucleic acid amplification test or culture. A nucleic acid amplification test or culture can also be used to verify the causative agent of nongonococcal urethritis. In fact, the laboratory test of choice for the presence of Chlamydia trachomatis is a nucleic acid amplification test because of its high sensitivity and ability to detect all Chlamydia trachomatis biovars. Treatment for nongonococcal urethritis will depend on the causative agent. Because Chlamydia trachomatis lacks a peptidoglycan cell wall, beta-lactam antimicrobials such as penicillins and cephalosporins will be ineffective. Therefore, the treatment of choice for Chlamydia trachomatis genital tract biovar is either 1 gram of azithromycin taken orally in a single dose or 100 milligrams of doxycycline taken orally twice a day for 7 days. Alternative treatment options are 300 milligrams of ofloxacin orally twice a day for 7 days or 500 milligrams of levofloxacin orally once a day for 7 days. Pregnant women should take 1 gram of azithromycin orally in a single dose. If pregnant women are unable to tolerate the recommended treatment, they should instead take the recommended dosage of amoxicillin or erythromycin. In all treatment cases, patients should take their antibiotics following the exact directions of their doctor. Sexual activity should also stop until all the medication prescribed is finished and all symptoms are gone. The Centers for Disease Control and Prevention does not publish rates of urethritis as a syndrome. Instead, they break down sexual infection rates of urethritis by etiology. Urethritis caused by Chlamydia trachomatis was the most reported sexually transmitted infection in the United States, with over 1.5 million new cases in 2016, accounting for 15 to 40% of all nongonococcal urethritis cases. Unfortunately, rates of nongonococcal urethritis continue to rise annually, as shown by the estimated increase of 4.7% from 2015 to 2016. Trends show that Chlamydia trachomatis is the most reported cause of nongonococcal urethritis in males and assumingly in women as well. However, the high rates of asymptomatic women and lack of reporting make it difficult to know. Reports of nongonococcal urethritis are highest among adolescents and young adults, with risk factors that include young age, unprotected sexual intercourse, and multiple sexual partners. Racial disparities also exist. African Americans are 5.6 times more likely to be affected by Chlamydia trachomatis genital tract biovar when compared to Caucasians. The percentage of people infected by a particular nongonococcal urethritis pathogen can vary greatly because many who are asymptomatic do not know that they are infected and therefore do not get tested. Lymphogranuloma venereum is an ulcerative sexually transmitted infection of the genital area caused by a particular biovar of the bacterial pathogen Chlamydia trachomatis. Again, Chlamydia trachomatis is characterized as a small, aerobic, coccoid or rod-shaped gram-negative obligate intracellular parasitic bacterium whose cell wall lacks peptidoglycan. This time, however, as I talk about Chlamydia trachomatis, it will be in regard to Lymphogranuloma venereum. Therefore, I will be referring to the Lymphogranuloma venereum biovar, which mainly affects the lymphatic system. While the genital tract biovar is a very common sexually transmitted infection, the Lymphogranuloma venereum biovar is rather uncommon for a sexually transmitted infection. To reiterate, the mechanism of contracting Chlamydia trachomatis is through sex that involves direct mucous membrane contact with an infected individual. This may be vaginal, anal, or oral sex, and ejaculation does not have to occur. The pathogen can also be passed by sharing sex toys or by touching the genitals with fingers that have infected fluids on them. Even though Lymphogranuloma venereum is caused by a different Chlamydia trachomatis biovar, it still utilizes the same mechanism and developmental cycle in which the pathogen alternates between the extracellular infectious elementary body and the intracellular non-infectious reticulate body. However, the Chlamydia trachomatis Lymphogranuloma venereum biovar primarily affects the lymphatic system, extending from the primary site of infection to the regional lymph nodes by infecting lymphatic epithelial cells and macrophages. This causes a lymphoproliferative reaction. From here, tiny necrotic foci infiltrated by neutrophils represent the earliest microscopic change in an affected node. These enlarge and coalesce to form the ulcers that represents the most characteristic feature of the disease. Once Chlamydia trachomatis Lymphogranuloma venereum biovar enters the host, symptoms follow a three-stage pathway. The primary stage begins about 3 to 12 days after exposure, but may take up to 30 days. It is characterized by the development of painless genital ulcers or papules on the penis or vagina that can range from 1 to 6 millimeters in size. These lesions usually resolve spontaneously within a few days. Sores may also become present in the mouth or throat. This stage often goes unnoticed, especially in women due to the location of the lesions and as the lesions are small with no associated symptoms. However, an inflammatory reaction can occur at the site of inoculation. The second stage occurs 2 to 6 weeks after the primary stage and is characterized by the onset of inguinal syndrome and/or anorectal syndrome. Inguinal syndrome refers to the development of swollen, tender, and painful lymph nodes in the groin or pelvis or near the rectum. Swollen and tender lymph nodes in the groin are more common in men, while swollen and painful lymph nodes in the pelvis or near the rectum are more common in women. Anorectal syndrome refers to the development of proctitis or proctocolitis-like symptoms and usually occurs when transmission is via the anal route. This may include pain during urination, rectal bleeding, pain passing stool, abdominal pain, anal pain, and tenesmus. When transmission is through the oral route, symptoms may include swollen and tender lymph nodes in the head or neck, which could lead to pneumonia or hepatitis. Drainage of blood or pus from the sinus tract may also occur. The third stage usually occurs when Lymphogranuloma venereum has been left untreated. This stage is characterized by necrosis or rupture of the lymph nodes, anogenital fibrosis or stricture, anal fistulas, deformed genitals, and pelvic floor dysfunction. A definitive Lymphogranuloma venereum diagnosis can be made only with Lymphogranuloma venereum specific molecular testing, such as PCR-based genotyping. These tests can differentiate the Lymphogranuloma venereum biovar from the other Chlamydia trachomatis biovars in rectal specimen. However, these tests are not widely available, and results are not typically available in a time frame that would influence clinical management. Identification of Chlamydia trachomatis in genital, rectal, and lymph node specimens can also be tested using a nucleic acid amplification test or culture. Nucleic acid amplification tests are preferred because of their high sensitivity and their ability to detect all Chlamydia trachomatis biovars. Serology tests to diagnose lymphogranuloma venereum should only be used in cases of isolated inguinal or femoral lymphadenopathy for which diagnostic material of a chlamydia trachomatis nucleic acid amplification test cannot be obtained. Therefore, diagnosis of lymphogranuloma venereum is often based on clinical suspicion, epidemiological information, and a chlamydia trachomatis nucleic acid amplification test at the symptomatic anatomic site. Because diagnosis can take so long, patients with a clinical syndrome consistent with lymphogranuloma venereum should be presumptively treated, mainly those showing signs and symptoms of proctocolitis, such as proctitis, bloody discharge, tenesmus, or ulceration. In cases of severe inguinal lymphadenopathy with bubal formation, particularly if the patient has a recent history of a genital ulcer, or in the presence of a genital ulcer if other etiologies have been ruled out. The goal of treatment is to cure infection and prevent ongoing tissue damage, although tissue reaction to the infection can result in scarring. Buboes might also require aspiration through intact skin or incision and drainage to prevent formation of inguinal or femoral ulcerations. The recommended treatment against chlamydia trachomatis lymphogranuloma venereum biovar is to take 100 mg of doxycycline orally twice a day for 21 days. Alternative treatments are taking 500 mg of erythromycin base orally 4 times a day for 21 days, or taking 1 gram of azithromycin orally once a week for 3 weeks. Pregnant patients should be treated with erythromycin. Doxycycline and other tetracyclines should be avoided in pregnancy due to the risk of disruption of bone and teeth development. Patients who have fluctuant or pus-filled buboes can benefit from aspiration of the node, which provides symptomatic relief. However, incision and drainage of the nodes are not recommended as it can delay the healing process. Lymphogranuloma venereum is common in the tropical and subtropical regions around the world. It is rare in the United States. Lymphogranuloma venereum may occur at any age, however, the highest incidence of the disease is in the sexually active population between 15 and 40 years old. Lymphogranuloma venereum probably affects both sexes equally, although it is more commonly reported in men because early manifestations of lymphogranuloma venereum are more apparent in men. It is endemic to men who have sex with other men. Men typically present with the acute form of the disease, whereas women often present when they develop complications from later stages of the disease. An association with lymphogranuloma venereum has been shown in the acquisition and transmission of HIV. Chancroid is a highly contagious, sexually transmitted genital ulcer disease that results in painful, superficial ulcers, often with regional lymphadenopathy. Chancroid is caused by the bacteria Haemophilus ducreyi. Haemophilus ducreyi is a gram-negative, rod-shaped, facultatively anaerobic, non-motile pathogenic bacillus. The pathogen that causes chancroid can be passed from person to person in 2 ways, the first being through sexual contact with a person who has open sores. The second is when the pus-like fluid from the sores is passed from person to person through other physical contact, meaning if you have open chancroid sores, touch one of them, and then touch another person, you may pass the infection to them, even if the activity was not sexual. Scientists think that the pathogen enters the body through microabrasions in the skin, typically during sexual activity, as it usually doesn't infect skin that doesn't have any abrasions. Symptoms usually occur within 4 to 10 days after exposure. The most common symptom of chancroid are painful, tender, and non-indurated genital ulcers. The lesions begin as tender pustules that break down to form painful, soft ulcers with a necrotic base and irregular borders. Multiple lesions and inguinal adenopathy often develop. The ulcers are also soft to the touch. In inguinal adenopathy, lymph nodes around the groin can become swollen and painful. With lymph node involvement, fever, chills, and malaise may develop. Other symptoms of chancroid include dysuria, vaginal discharge, rectal bleeding, pain in bowel movements, and dyspareunia. If left untreated, individuals run the risk of progressing to painful regional lymphadenitis and the development of suppurative buboes. Reports of asymptomatic chancroid are uncommon considering the ulcers are typically very painful. However, women show much higher rates of being asymptomatic than compared to men. Along with being asymptomatic, women may only develop sores inside their vagina. Therefore, their only visible symptom may be swollen lymph nodes, which they might not notice if they have no other symptoms or medical problems. The diagnosis of chancroid based on clinical findings is made challenging by its potential similarities to lesions associated with other more common causes of genital ulcer diseases, such as syphilis and herpes infections. A probable diagnosis of chancroid can be made if all of the following criteria are met. The patient has one or more of painful genital ulcers. Clinical findings, the appearance of genital ulcers and any presenting regional lymphadenopathy are consistent with chancroid. There is no evidence of syphilis-causing agent, treponema pallidum, by dark field examination of ulcer exudant or serous fluid, or by serologic tests for syphilis performed at least 7 days after onset of ulcers. And finally, a herpes simplex virus nucleic acid amplification test or herpes simplex virus culture performed on the ulcer exudate is negative. A definitive diagnosis of chancroid requires the identification of Haemophilus ducreyi on special culture media. However, this culture media is not widely available, and even when the media is used, the sensitivity is less than 80%. There also is no FDA-cleared nucleic acid amplification test for Haemophilus ducreyi in the United States. However, such testing can be performed by clinical laboratories that have developed their own CLIA-verified nucleic acid amplification test. Successful antimicrobial treatment for chancroid can cure the infection, resolves the clinical symptoms, and prevents transmission to others. In advanced cases, however, genital scarring and rectal or urogenital fistulas from suppurative buboes can result despite successful treatment. There are 4 recommended treatments for chancroid. They are 1 gram of azithromycin taken orally in a single dose, 250 milligrams of ceftriaxone given intramuscularly in a single dose, 500 milligrams of ciprofloxacin taken orally twice a day for 3 days, or 500 milligrams of erythromycin base taken orally 3 times a day for 7 days. It should be noted that intermediate resistance towards ciprofloxacin and erythromycin have been reported around the world. However, data is limited regarding prevalence of Haemophilus ducreyi antimicrobial resistance. The time required for complete healing depends on the size of the ulcer. Large ulcers might require more than 2 weeks. In addition, healing can be slower for uncircumcised men who have ulcers under the foreskin. Also, clinical resolution of fluctuant lymphadenopathy is slower than that of ulcers that might require needle aspiration or incision and drainage, despite otherwise successful treatment. Although needle aspiration of buboes is a simpler procedure, incision and drainage might be preferred because of reduced need for subsequent drainage procedures. Patients should be re-examined 3 to 7 days after therapy initiation. If therapy is successful, ulcers usually improve symptomatically within 3 days and objectively within 7 days after therapy. If no clinical improvement is evident, the clinician should consider whether the diagnosis is correct. Another sexually transmitted infection is present, the patient has HIV, the treatment was not used as instructed, or the Haemophilus ducreyi strain causing the infection is resistant to the prescribed antimicrobial. Challenges to understanding the true global incidence of chancroid are based on difficulties in isolating the causative agent and the limited diagnostic and surveillance modalities available to the clinician. Part of the problem is that chancroid is often lumped in with other conditions under the term genital ulcer disease. Chancroid is extremely rare in the United States and other developed countries. However, infection is still shown to occur in Asia, Africa, and in the Caribbean. In the United States, only 7 cases in 6 states were reported to the Centers for Disease Control and Prevention in 2016. The reported cases involved a spectrum of individuals, including minorities, heterosexuals, and prostitutes. As chancroid is a genital ulcerative disease, its lesions are more readily apparent and therefore more commonly reported among men. Uncircumcised males tend to have a greater incidence than those individuals who are circumcised, and women tend to be more asymptomatic. Chancroid also has been found to be a significant cofactor in the heterosexual acquisition and transmission of HIV. Genital ulcers may increase the risk of HIV infection by as much as 50 to 300-fold for each unprotected encounter. Interruption of the mucosa in the genital ulcer disease provides a portal of entry for HIV. HIV in turn may alter the appearance and clinical course of chancroid. This may include an increase in the incubation period, multiple ulcerating lesions, delays in healing, and poor response to standard courses of antibiotics, or treatment failure.